but I think some will be longer to answer.
All right. So we'll be wrapping up around 10, it sounds like. All right. Well, I will try. I'll try and be as concise as I can. I sometimes get long-winded, and I will guard against that. And then, so I guess just fire them away. And Carrie, if you can scan the list, and if there are duplicate questions, kind of merge them so that we can give them the full attention, hopefully.
There is a question here, one of the early questions about sort of the half-life of the coronavirus, how long it lives on various surfaces, and the impact of cleaning and sanitation measures with respect to that.
Okay. Sure. So that is that's a complicated question on which one could easily spend a half hour. But what I will say in a nutshell is that the data about the half-life comes from testing for RNA, not live virus. So that very likely vastly overestimates how long surfaces are actually infectious. It's hard to know by how much because testing for live virus is actually much more complicated. What most of the studies have shown is that the virus can be detected, or at least the RNA from the virus can be detected for several days on hard surfaces, particularly if those surfaces are moist. So things like metal and plastic and things like that will harbor the virus for longer. Things like cloth and cardboard and paper don't harbor the virus for very, very long at all. Probably no virus is detectable on those surfaces within a day or two. But the concept of half-life is really important to understand here. So when studies like this are done, typically what they do is they take something like 10 million or 100 million virus particles, and they put them on the surface, and then they resample that surface periodically. And as long as they can detect anything, that surface is still considered contagious, even when it's down to just one particle. And typically what happens is things decay by half. So if you started off with 10 million virus particles, and you said that the virus was still detectable for 7 days, it probably means that the half-life is measured in a few hours. So you start off with 10 million, and then a few hours later, you're down to 5 million. A few hours later, you're down to 2.5, and so forth. How many viruses have to be on the surface in order to get it is not something that's precisely known, but it's certainly likely to be more than one. So when you see something that says a surface can be like a doorknob can be contagious for as long as a week, it's probably very contagious for the first few hours after it's been touched. And then a day or two later, even if you can still detect virus RNA there, it may not be very contagious at all. I think a lot of the attention that has been placed on surface decontamination skirts the fact that the vast majority of transmission of this virus is through the air. It's in droplets that people are coughing and spraying when they talk and cough and sneeze and things like that. And surfaces are a very minor issue, a very small component of how much virus transmission actually happens. The surfaces that probably matter are the things that people touch frequently in rapid succession. So things like railings and doorknobs and cell phones, if you pass them around to look at your selfies, those are the sort of surfaces that people may be able to pick up virus from. I'm not worried at all about people picking up virus from most other surfaces. That it's probably not relevant at all to most of the transmission that happens. And so when you hear about things like schools closing for an entire day to fumigate the place, that's a huge effort that, in my view, is actually largely wasted. And I think really what people ought to be doing is focusing attention on frequently cleaning those surfaces that are touched very often. I think that would go a lot further towards reducing transmission than worrying about mopping the floors and wiping down the walls and things like that. Those things probably don't matter at all.
Thank you.
I second exactly what Dr. Snedeker said. While theoretically people might be able to contract coronavirus from surfaces, it is not the way that it's typically spread. And I don't think that there are many, if any, cases at all of people catching it that way. But it's still extremely prudent to be doing frequent hand washing, using sanitizer, and cleaning surfaces that are high touch, frequent touch by different people.
Right. The best protection against all of those things is sanitizing your own hands frequently.
There's another series of questions that allude to the comments you've made previously, I think in the board meeting, about sort of the timeline for the resolution or some better interventions with respect to COVID. If you could, sort of recap those comments, that would be appreciated, because I think that would attend to a number of the questions here.
Okay. Yeah, and I understand that there was some communication from the board a couple of days ago in which I was quoted, and I'm not sure that the context for my comments was fully represented. So what I said to the board and what I said to Adam and the smaller group that we met with a couple of weeks ago is that the current situation that we are in right now with respect to the risk of coronavirus in the community is about as good as it's likely to get for a long time. We have a very, very low transmission rate. We have a lot of testing going on, a lot of surveillance, even though it's not random surveillance, but lots and lots of people are being tested. And so we are in a better position than just about any place else in the world right now. And it's not going to get any better anytime soon, because still only a very tiny proportion of the population has had the virus so far. So lots of us are still susceptible to getting it. And the prospects that there will be a vaccine that will make this all go away by the end of the year is nuts. It is not going to happen. It is probably not even going to happen by the end of next year, in my estimation, although I think there's certainly substantial efforts to get an effective vaccine out, but there are many, many barriers to that happening. And if you've been following the news, you heard yesterday about one clinical trial that was shut down because of one possible adverse effect in one patient. And I bring that up not to say that vaccine development is scary, but just to say that there's lots of hurdles to get through before you can actually get something out there. Under the best of circumstances, let's say we got a vaccine out there that was 70 to 80% effective and extremely safe. You then have to get that vaccine out to somewhere between 200 and 300 million people in order to achieve population immunity. And that is no small task, particularly when probably tens of millions of those people are not going to want it. The polls that I've been hearing about suggest that more than half the population, if offered the vaccine, wouldn't take it right now. And so if that situation continues, there's no hope of getting vaccine level immunity in the population. So, my best guess, and it is only a guess, I don't have any special knowledge about this other than what I've just told you, but my best guess is that we will be in the same situation that we are in now, probably for 2 to 3 years. And I say that without any agenda behind it. It's just reality. And so if the board, when I was aware of their decision to not open the school, and I know that there were many considerations that went into that decision, it was a very tough one to make. But if we can't open the schools the way things are now, there is no hope of it being better anytime soon. It can only be worse. It may just be the same, but if people start letting down their guard and start getting lazy about physical distancing and things like that, rates could increase. With winter season, it's possible that rates might increase, although there's no real reason to think that this virus has any seasonality whatsoever. And so the notion that, the summer, it's all going to go away, and then it may flare up hugely in the fall, there's no biological reason at the moment to think that that's going to happen. And most virus seasonality happens because of our behavior more than it does virus biology. It happens because in winter, we spend a lot of time indoors with lots of other people, and it's a lot easier to pass stuff like that around. So those were my comments, just in terms of the epidemiology of the virus and where we're at right now and where we're likely to be going. And this is not going to be going away in just a few months. And so any decisions that we are making about things like opening businesses and opening schools and running hospitals and medical practices, we have to deal with where we are right now, but we also have to think about the long game because we're going to be in this situation for a long time.
Thank you, Dr. Snedeker. Lily, if I could pivot to you, there's a couple questions I think you'd be best posed to answer. One is with respect to mask wearing among students, and what is our response for students who are struggling with consistently adhering to our new health and safety norms?
Yeah, that's a really good question and certainly a topic of discussion often. So before I talk about mask wearing, I always want to make sure that we're remembering that we have a layered approach to all of our health and safety protocols, right? That starts with health screener every day, right? Physical distancing, exercising, practicing good hand hygiene with hand sanitizing stations that are all throughout our buildings now, and auxiliary sinks and sinks that are fixed now within our spaces, enhanced ventilation and filtration systems, enhanced cleaning and disinfecting protocols, and many, many more supplies, et cetera. So mask wearing is one of those layers that's within all of those health and safety protocols, right? So when kids are, you know, before kids join us, you know, we've been working with administrators throughout the summer, teachers throughout the summer, folks thinking about how to pre-teach mask wearing, right, and support students in actually donning those masks and wanting to wear the masks. From one of our colleagues who I believe I just saw on this call, you know, is really talking about making sure that kids are wearing masks that they feel are representative of their identities, that they're interested in, they think are cool, right? Especially for some of our younger kids. So there's teaching, there's support at the beginning in order to prevent. But of course, we know there are going to be some kids who simply cannot medically tolerate mask wearing, right? And that's in the guidance. It may have an adverse effect on their mental health or their physical health, right? So there are going to be some exceptions for those kiddos. And then there are some who may just be having a really bad day or a series of really bad days, right? And maybe continuing to take them off, right? Or are just being rude, right? And so obviously we want to engage in restorative practices as much as possible. And there may come a time when we say, hey, you've got to learn from home today. Can't do this, right? We've worked with you over and over, and this is not a sustainable situation. You're going to learn from home. We can try again another time, right? We want to approach each situation individually. We also know that this is serious, right? And so that ultimately is our approach. Carrie, did you want to add anything to that?
Yeah, just one thing to add. Dr. Dendali and I regularly meet weekly with nurse leads from other districts. Dr. Dendali actually provides support to other districts in addition to the Ithaca City School District. And many of these schools opened this week. They had their first day, second day back in person. And so far, at least what we've heard from those head nurses was that compliance was very good among students. They didn't report any issues, at least with their first or second day. And so that's something we can continue to look at, the experience in other schools and how they are supporting students with respect to mask wearing behavior. Is there something you want to add?
No, and I also think people are afraid that we're going to get a gazillion mask exemptions, but really it seems the majority of the people want their children wearing masks, so we haven't really received that many. So I don't think that's going to be a concern at all.
I can say that in my office, you know, all of our kids, every child over 2 who comes in our office is expected to wear a mask. We've had no trouble, whatever. We've had no resistance from parents. The kids often are more compliant with good mask practices than their parents are, I must say. There is also, I second what Lily said about you know, that the mask is just one layer in the many layers of protection that you know, the district is trying to put in place. But there was an interesting analysis that came out a couple of weeks ago of daycares in Rhode Island. And so for the months of June and July in Rhode Island, daycares were allowed to reopen at a time when their population COVID rate was probably about 10 times what ours is at the moment. And out of 650 roughly daycares that were open during that time, only 29 during that entire 2-month period had any cases of COVID in the daycare. Almost all of those had only a single case. So that one kid who they got them out and there was no secondary transmission. In only 3 of the daycares did transmission from child to others actually occur. And I mention this because the state rules on opening daycares required that the caregivers wear masks, but did not require the children wear masks in the daycares. So I think that's fairly significant. Now, I'm sure many of the daycares were actually having the kids wear masks, you know, of their own volition. But nevertheless, it suggests that even if you take that particular element away, if you are doing all of the other things like keeping class size small and screening for symptoms and doing hand hygiene and all the other things that they were also required to do, that the mask is not sort of the critical element where if you lose that, you've lost everything.
Dr. Snedeker, I'd like to just add a few things with respect to masks. We talk about them frequently as a tool for protecting others, which it certainly is. First and foremost, we are protecting others, but there's some interesting research emerging that confirms that mask wearing protects the wearer as well. There was a study that the CDC published, a case study of 2 hairdressers who were positive for COVID, saw dozens of clients, at least 15 minutes each. The clients and the hairdressers wore masks, and they did extensive contact tracing and testing and did not reveal any subsequent cases. Additionally, there have been some animal studies with hamsters. I just happened to read a paper on this, that suggests that the mask may also impact the amount of virus you're exposed to. There was a seafood or fish packing plant in the Pacific Northwest. Mask wearing was required. They handed out masks to the staff every day. They found a positive case. They tested, I believe, about 500 members of that particular packing facility. 95% of them tested positive, but they were also asymptomatic. The remaining 5% had mild to moderate symptoms. So there does seem to be not only the benefit of you preventing the spread of COVID, because you yourself may be the asymptomatic or pre-symptomatic carrier, but that the mask also serves as protection for you, such that if you are exposed, it could potentially lessen the resulting symptoms or seriousness of your COVID infection. And Dr. Snedeker, you're welcome to comment on that or correct me if you feel you need to.
Yeah, it's very interesting studies that are coming out about this. And while it's hard to quantify these things precisely, I think the effect on inoculum really is very intriguing. And what I mean by that is that how sick you get when you get coronavirus may depend on how much virus you inhaled at the moment that you were infected. So if you're infected with 1 billion virus particles, the virus is off to the race in a hurry and your immune system doesn't have time to catch up with it. If you're infected with 10 or 20 particles, those viruses have to replicate within you, they have to divide and grow. And as soon as they're starting to do that, your immune system is having an opportunity to react to it. And I think that may be what Carrie is getting at in referring to the very low rates of symptomatic infection in people who were wearing masks even if they got exposed. So it does seem, even for cloth masks, that wearing masks does protect the wearer as well, not just the people around them from the wearer. So I think, and that is reassuring. It means if you're wearing a mask and you're around somebody who isn't, you're still getting mileage out of that mask that you've got on.
There's a question here that I feel confident in answering, and anyone who wants to add to it, I welcome them. But yes, we will be providing flu clinics. Someone asked if we're doing that. Yes, we've scheduled them. I sent out a flyer to district administrators early this morning Posters will be in buildings next week, and we will be making it widely available to staff so they understand where and how they can get a flu shot. The earliest clinic, I believe, is October 10th. And again, information will be available. Would any of the providers like to discuss the importance of the flu vaccine, particularly this year?
Well, I think it's important in a number of ways. One is that, of course, if you develop any flu-like symptoms, you are instantly going to be a COVID suspect. So it will make life more complicated. So if you can prevent even one instance of that happening, it's a good thing. It's also certainly possible that co-infections may happen. So there isn't any reason that you can't have flu and some other virus at the same time, which may potentially increase the likelihood of transmitting both of them. So I think there are good reasons for everybody to take full advantage of flu vaccine this winter, although getting flu vaccine in no way provides any direct protection against COVID.
Anything you want to add to that?
No, some of the practices like Northeast Pediatrics are already offering flu vaccines. I believe you have a drive-through, and I know they're
Yes.
offering them at Wegmans too, and I'm not sure about the other practices.
Yeah,
But
and most of
there-
the pharmacies in town are doing it too. And in New York State, there's still currently an exemption from the restriction against pharmacies giving vaccines to children. So they are allowed to give flu vaccine, I think, down to kids as young as 2. Not all pharmacies will do that, but many of them are.
I would only add that some of the private practices are later in getting their flu vaccine. So rather than waiting for your primary care doctor to have it, I know we're not getting ours for another month, then I would encourage my patients just to do what's most convenient for them to ensure that they get it in a timely manner.
Yeah, we don't have tons of it either. We usually get our shipments in a couple of installments throughout the season, and Wegmans always gets theirs at least a month before we get ours.
And it's
It's just the
sometimes
reality.
hard, excuse me, and it's sometimes hard for the private practices to get more once they run out. And that's happened to us in past years. So getting it when you can, sooner rather than later, is the best idea for all of us.
Lily, there's a question here about whether our school community will engage in surveillance testing, and if so, what that would look like. Would you be willing to initiate an answer? And I think then the physicians can speak to the value of testing.
Sure, I can talk about the guidance and public health law as it stands right now, and then turn it over to the doctors if that works. So the New York State Education Department and the New York State Department of Health, when they put out their extensive guidance in July, they strongly discouraged school districts from engaging in testing all students and staff, and they cited the CDC.
Hello.
And
Hi.
hi, Elizabeth, we can hear you. Great. All right. Nice to see you, Ms. Elizabeth. Hi. And also public health law prohibits us from administering any sort of medical test without parental consent. So each time we would, if we were to engage in surveillance testing, we would need to require parental consent for each of those tests, right? And so if we don't receive that, then that's not full surveillance testing as well. I do know that Cornell they've done extensive work in terms of setting up their labs, and are now engaging in, of course, the pool testing that we're seeing in the Cornell COVID dashboard, and we're able to see those results. I will also say that we have been in conversations with them to learn more and understand what that program is, and any potential collaborations if the laws change and the guidance changes, so that we can keep that conversation going if need be. at this point, I should probably turn it over to Dr. LaFace, Dr. Snedeker, Dr. Dali, if they have, I'm sure they have plenty more to add about surveillance testing.
Lily, I just have a couple more things from a regulatory standpoint. So any building where we are conducting testing, we have to submit an application and payment to the Department of Health to become a limited use laboratory. So that should be clear. There's also questions around resources with respect to staffing. You know, who would do that? Who would be responsible for the sampling? At Cornell, they have observers, and students are doing their own nasal swabs. You can imagine that might be difficult for some of our very young students. They would actually need someone probably to do that swabbing. And then those persons would need appropriate PPE. And if they're non-medical personnel, they would need training to do that. In addition to the throughput issues, which is something Cornell continues to work through. I have a student I'm working with who waited, I think, over an hour to be tested and ended up missing a better part of her graduate class because of it. So there's certainly limited resources, limited time with respect to conducting testing. And then I think something that folks don't often talk about is the cost of testing. Cornell has publicly said that this semester they're expending $3 to $5 million and potentially $10 million over the course of the school year to engage in testing. There have been no federal or state funds made available to school districts to engage in the level of surveillance testing that you see occurring at a place at Cornell. You want to add, you or Dr. Snedeker?
Yeah, I'm going to defer to Dr. Snedeker because I feel like he is the expert, and I always defer to you, Dr. Snedeker. You're amazing.
That's not always wise. I really don't have much to add to what was just said, except that if you're going to be adopting surveillance testing, you've got to go all in. You have to do it as frequently as Cornell is doing it and as intensively as they're doing it. And you have to have very rapid turnaround in order to be able to act on the results of testing if it's going to be meaningful. And that's a huge lift. There are huge costs associated with it. It takes a tremendous amount of people power. And as Carrie said, there are currently regulations that make it very difficult to implement that practically in the school setting. If all of those barriers could go away, I would love to be testing everybody the minute that they walk in the door and have their result 15 minutes later and be able to say, no, you can't go to school today. But I just don't see how that is feasible in the near term. It may become feasible at some point, but we're definitely not there right now.
I'd also just like to add, Carrie, if you don't mind, I'd just also like to add that for employees of Ithaca City School District who utilize the ICSD insurance, we will cover any COVID testing co-pays that anyone may incur. So we, of course, want to encourage folks to get tested if they're, if they're concerned, they're symptomatic, right? Or have come in contact, right? And it's also important to note that if you're a Tompkins County resident through, I believe it's November, what is it, Carrie?
The second week of November.
The second week of November, the Tompkins County legislature opened it up. So the mall testing site, anyone can sign up to go there regardless of whether they're symptomatic or not.
And I think it still remains true that any child who is excluded from school because of symptoms that could be compatible with COVID has to be tested in order to return before the automatic quarantine elapses. There is, and that will be, I'm sure, I believe that's true of staff as well, but that anybody who is symptomatic will be required to have been tested, and if they are coming back sooner than the 10-day quarantine period, they have to be evaluated by a physician and have an alternative diagnosis.
Dr. Snedeker and everyone else on the call, it is established in the research literature. We heard it from the folks at Cornell and other sources that again, that it's a layered approach. Testing alone in and of itself is not perfect either. There is the risk of false negatives, particularly early in the course of the illness, that someone may effectively not have a detectable amount of virus in their symptom. So day 1, day 2, day 3, they could have a negative COVID test when in fact they actually are carrying the virus. And I will defer to our infectious disease expert, but I believe that's been, sort of established.
Right. Testing represents one moment in time. And so you can be incubating the virus and test negative, and then, you can be contagious a couple of days later. And that's why if you're going to be doing blanket testing like that, you have to do it very frequently in order for it to really be effective. If you're doing it once every 2 weeks, it's not really going to have much impact.
So there is still quite a few questions, but Adam, I don't know if you want to open it up to persons who are on the line to ask those live. Some may be very specific.
Sure. Yeah, we're about 45 minutes in now. I think the explanations and the answers so far have maybe helped. There's a few in the chat. Maybe we could keep track of those. Those aren't going to go away, but the people might who are on the screen. So I'm trying to think the best way to do this. So if something was not answered or your question in the list that you submitted via the link wasn't answered, I guess this would be a time for us to kind of either raise your hand and I can unmute you, or you can unmute yourself and we'll try to figure out how to take turns with your question.
Adam, can I just add that if we don't answer questions tonight, we would be happy to answer the questions at another point. So just, yeah, if they're by email. So we can just fill that document and we can continue to answer the questions.
Sure. The questions that are in the chat will obviously be saved and we can merge those with the form that you're seeing live in front of you. So let's go to someone that's unmuting themselves. So it looks like Leland, do you have a question or are you just unmute? Okay,
Sorry, no, I don't.
All right, I'm going to mute him. There we go. Okay. So there is a raise hand function, I believe. Maybe that's not working. So if you want to unmute yourself, just shout out, I have a question.
Adam, I do have a question.
Sure.
This is actually from someone who couldn't be there tonight. And they asked that someone ask this, so I'll do that.
Hey, Lisa, go ahead.
She says, I watched the video of Dr. Snedeker's presentation to the school board on 8/25 carefully, as it seems this presentation influenced both the board and ICSD administration to push for making fully in-person instruction available for all families who wish. At 1:28 in the recording, Dr. Snedeker says the following: if we were having 50 positive cases in the county in a week, no matter what you're doing in school, you wouldn't be able to keep it under control. The number of active cases in our community is currently significantly higher than 50, and our county now has the second highest number of positive cases per capita in the state. I'm wondering if there's a threshold number of COVID cases in our community that would lead you all to recommend closing down in-person school, and if so, what that number would be.
If I could, I may have something to add here, and then again, I invite the healthcare professionals to discuss this. So one of the reasons that certainly the number of positive cases are growing in the fashion that they have is because of the frequency of testing at Cornell. They currently test undergraduates twice a week, and grad students, faculty, and staff at least once a week. And so what they're effectively doing is uncovering asymptomatic or pre-symptomatic cases that might otherwise go undetected. I did happen to speak with a public health nurse on Tuesday morning, and I was able to ask questions with respect to their work. What she indicated was that they have not seen spillover occurring from the Cornell cases into the broader community. They also indicated that the majority of those who tested positive were individuals who were already in quarantine. That original group of sort of 9 or 10 students who were identified led to about 70 or so being involved in contact tracing and asked to quarantine. So the positive results that were coming through, many of them were already effectively receiving those daily calls from the health department and isolating in their own spaces. And then I think, what was the last thing I wanted to say? I forgot.
I don't know, but I have something to add. I think it's a little bit of a hard question too, because like Carrie said, the cases could be grouped in different places. And so, you know, when I spoke with the Department of Health and asked about school closing and what rate would be closed, you know, it's hard to answer because, you know, if all of our cases are in one classroom in Boynton, you know, maybe we just close down that classroom, or if all of them are in DeWitt, then we close down the whole school. So it would depend on what was really going on, how it was spreading, what the community spread is.
And that, okay, thank you. You prompted me. And then the last point, my question I sort of asked was, you know, is this exceeding your capacity to stay on top of it? Because having cases is one thing. You get into a more difficult place when you're not able to effectively contact trace, quarantine, and isolate. So it's when cases are spreading and the health department is unable to identify, interrupt chains of transmission, that is when we start having issues and problems. So identifying sort of hard and fast numbers for closure is really difficult because there are a lot of dependencies that play into it. And it has to be driven in large part by the health department's contact tracing investigation.
Dr. Snedeker, Dr. LaFace, do you have anything to add to that?
Well, since I was quoted, let me respond to that. So, you know, I picked a number out of the air. I will admit that, but it wasn't a completely random number. At the time that I made that comment, the county was testing about 500 people a day, roughly speaking. So that would correspond to a rate of positivity of 10%. The governor has set down a mandate, actually, that if the testing rate is more than 9%, that the schools must close. For me, 9% is way too high. That, you know, that may not be the number, and I'm not in a position really to comment on what the school's policy might be about that, except to say that it is correct that so far the cases that are being detected at Cornell are mostly people who have already been quarantined, and there's no evidence so far of spillover to the community. So the community rates are staying very, very low at the moment. There is no guarantee that they will stay that way, but at least for the first 2 weeks or so that Cornell has been in operation, they have not budged.
Thank you very much.
Hi, can I ask a question?
Go ahead, Tora, yes.
Thank you. So I came in a little late, so I apologize if you all already answered this, but I receive, you know, from the Center of Disease Control sort of updates. And there was something that came through my phone the other day about the MIS-C, the multi-system inflammatory syndrome, that is specifically has to do with children, a condition where different body parts can become inflamed, including the heart, lungs, kidney, brain, skin, eyes, or internal organs. Children with MIS-C may have a fever and various symptoms, including abdominal gut pain, vomiting, diarrhea, neck pain, rash, bloodshot eyes, etc. It is related to COVID-19, and it's related to kids who may have had the symptoms or the virus, and then it's coming, showing itself later, or children who have been around people with COVID-19. And I'm just curious if you all know anything about that, and if you do, what do you know?
Yes. So the first thing to say about that disorder is that it is extremely rare. It's quite serious when it happens, although the vast majority of children actually get through it unscathed as best we can tell. My back of the envelope calculation, and this is a very crude estimate, based on the number of cases of MIS that were detected in New York City at the time when they were in the peak of the epidemic, is that perhaps somewhere in the vicinity of 1 in 3,000 children who actually have COVID may develop that syndrome. If every child in Tompkins County got COVID tomorrow, we might see 8 to 10 cases of MIS-C. That's just a ballpark estimate. It is probably what is happening with MIS-C is that the virus infection is triggering some sort of uncontrolled immune response that happens a couple weeks after the COVID virus is actually gone. But I don't anticipate that we are likely to see very much of that because it is such an uncommon disorder. It's a scary one, but it's quite infrequent, probably compared to the number of pediatric COVID infections that have actually occurred.
Thank you for speaking to that.
Nancy.
Hi, thank you so much for putting this together. I really appreciate it. And my question is about my work as a kindergarten teacher. I'm planning to return in person, and I kind of am embracing the idea that from Dr. Snedeker that if there's ever going to be a time that it's safe to do this, now is the time. My concern is that I don't feel like I'm getting the level of detail in the guidance on how to run a kindergarten classroom. I feel like so far the guidance on how we're going to teach in person and the health and hygiene are much more general and geared toward older students. And what I would like to see is between now and when we open, some point person or people that are, a team of medical and administrative or staff, teaching staff who can really look at the reality of how young children learn and play and be together, so that I and other teachers who are teaching in person of 4 to 6 year olds have a place to go with specific questions and know that the question on the other end is going to really understand early childhood. And one other thing I wanted to add to that. That I've been, because I haven't really felt a strong set of guidance around it, I've been asking people who either have a child in daycare or summer camp that was open this summer. And the sense I'm getting is that kids actually can play more like how they normally do. Then they don't have to be in this artificial separation, and they still can be safe, but that's not really the guidance I'm getting. So I just want to make sure I'm like hitting the right spot.
Folks, do you mind if I start there? Or Dr. Snedeker, I didn't know if you were.
I can chime in if you like. I think direct guidance like that would be very helpful. But I'm sure you can attest that in the kindergarten environment, whatever plans you make will immediately change as soon as reality hits. I think what I would say about that is that there are certain activities that happen in the kindergarten setting, like passing various things around the room and everybody handling them, that may be best avoided, or at least plan on having hand sanitizing activities happen after those things are shared. The fact that we have a very low rate of COVID in the community means that on any given day, the likelihood of any child in any kindergarten class having COVID right now is extraordinarily low. It's not zero, but all of the protections that we are doing are icing on the cake, if you like, of a pre-existing risk that right now is very low indeed. And I think if you can add on top just the common sense things, the hand washing that we've talked about, mask wearing as much as children can tolerate it, and having smaller numbers of kids in the classroom, that alone is going to get you 90% of the way to the finish line. There may be a few other more specific things, and Dr. Dondali, being a pediatrician, is in a perfect position to collaborate with the school administrators and to come up with a plan that's a little bit more specific. But I don't think you have to reinvent the wheel. I think there's a lot of common sense here that will get most of it done.
Thanks, Jeff. Yeah, and so I'm happy to work with you. You know, I think we could also look to other places like Denmark and the schools that have already opened that have had success with that. But I'm happy to work with you on things like how do we take mask breaks with kindergartners? How can we make washing hands fun, or anything you think that you need? I'm happy to be a part of that.
I think to add to that, many of the daycares could be helpful because they've been open since late May, and they've been certainly addressing issues of shared materials and small cohorts and spacing. So we can connect you with those persons to have conversations about what it looks and feels like, so that you can begin to imagine your own experience.
But I do think putting a group of people together is really good, because we're all trying to figure this out now. None of us really have answers, and we come at it from different ways. So I'm happy to be the medical person on that with you, because I know nothing about teaching, and I'm always amazed that you guys can get all the kids to nap at the same time when I can't even get one kid to nap at once.
Nancy, I'm thinking particularly images and videos of kids playing in this new era could be particularly helpful, perhaps, for folks too. So again, thinking a lot about shared materials and the ways in which we're actually really trying to teach kids to interact well together, and we want them talking and communicating with one another. And how do we do that while also keeping masks on? And then if we're using shared materials, then washing our hands immediately after. So I think seeing some of those processes, I think could be helpful as well.
Thank you. I'm just thinking mostly about the distance, the physical distance, because as much as I can, keep kids from, licking each other, I can't really. I can't imagine them successfully playing 6 feet apart, and that's the part that really is hard to get my head around.
Right.
I
I think obviously that's virtually impossible to enforce in a kindergarten environment, but having fewer numbers of kids there to begin with is going to be of some help there. All of the other things, the things that we do with masking and hand hygiene and so forth are done because we can't maintain physical distancing all the time. If we could, we actually wouldn't need a lot of those things. But the reality is that we can't anywhere in the public sphere realistically do that. And so all of those things on top of it are to mitigate some of the, natural exposure that happens because we can't all stay, the magic number apart from one another 100% of the time.
Okay, next question is Amy.
Hi, thank you so much for taking the time to thoughtfully respond to our questions and concerns. I teach on the secondary level, and my question is about cohorting. In your previous answers, you talked about the importance of staying in small groups and limiting the number of people that students come into contact with. And my question for you is, why are you recommending that so heavily, and how can that be handled in a secondary situation where our students are changing classes and intermixing and mingling during just other types of activities?
Well, I can comment on the reason why that's important, but I'll leave it to those associated with the district to comment on how it might be implemented. The reason it's important is just simple math. I mean, if you have 1 in 10,000 people in the community who have COVID at any given time, which is way more than we have right now, the likelihood that you're going to see it is greater if you spend time with 100 people or 200 people or 300 people that day than if you spend time with 10 or 20. So that's the rationale behind just trying to be around the smallest number of people that you can. In my daily life, I am going to work and I'm spending every day seeing children and families and so forth. So I'm around a large number of people, which is necessary in order to provide them the care that they need. But I don't look for opportunities to be around large numbers of people outside of my office. I haven't been to a restaurant since March, and I'm making quick trips to the stores when I need to, or doing curbside pickup, because the fewer people that I can be around, the less likely it is that I'll be exposed. It doesn't mean that I won't be, it just is improving my odds.
I would like to add to that another reason for having smaller cohorts is that not only are we exposed to fewer people, but if someone does turn up positive or having symptoms, then the contact tracing is not as complicated if you have fewer people to chase after and then chase after them, et cetera. So that's the other side of it. And like Jeff, I've been working continuously throughout the pandemic, exposed to patients who are well and also many, many patients who were very sick. And while we can't stay 6 feet away from people every moment of the day, washing our hands, wearing face shields if we're with sick people, and wearing masks has really prevented spread amongst the medical community here and also the community in general. So again, testing is important and distancing is important, but there are so many other public health efforts that we've learned work really, really well.
Can I ask a follow-up question to that, the cohort thing?
Heidi, go ahead, yes.
I'm just wondering about, there's many of us who are what we call itinerant. We're in several buildings, or people who provide service to many different classrooms in a building. How would you speak to that in terms of how safe that is to have people going from building to building, staff members working with children?
I can try to comment to this, but then I would defer to the health professionals. I think, so with respect to risk, there are a couple components to it. One is proximity, how close you are to people. Another is duration, how long. And so the health department is typically looking at like how frequently are you in contact with people who are less than 6 feet for 10 minutes or more. And then the third part of it is exposure. And so some activities, not all activities are created equal, right? A dentist providing care right now has much higher exposures than some other positions, right? And so it's a constellation of factors that play into risk. I think for people moving between buildings, certainly there may be an increased risk with the fact that you have, by virtue of doing that, more contact. And so then it becomes incumbent upon you to be more thoughtful about your personal practices with respect to mask wearing and hygiene, and also being mindful about the distance that you're maintaining between yourself and others. And again, how long, if you're violating, so to speak, the physical distancing piece, how long that's occurring and with how many persons. But I think for people moving between buildings, something that will be important is to keep a log or keep track of their movement within the district. Should they be involved with a contact tracing investigation or contact investigation, it's going to be important to note where you were and to keep note of who you were in very close contact with by virtue of whatever your functions are.
So utilizing this guidance, Adam and I were on a call today. We're currently trying to work through possibilities in order to adhere to this as best we can, understanding the in-person challenges of secondary with certifications, et cetera. So we're really trying to work through this in order to frankly decrease the number of interactions that folks are having in a given day. More to come soon.
Thank you.
I don't see a hand up, but I know that there's a huge question that's kind of bleeding through every employee's mind, which is this whole thing around like ventilation and how that does or doesn't help in this situation. So I don't know, I don't expect the doctors to be a scientist around filter levels, but I think it would be great if we heard the doctors' perspective on what they know about virus when it comes to ventilation systems, and then obviously hear from Carrie and Lily as to what it is that has been done, that's happening, and to be honest, and say like on this call, like we know this something has not been done yet. I think that people just want to know all three of those stages.
So the importance of ventilation depends on how many people are in a space for how long and what they're doing. You know, if you're passing somebody in a hallway and your contact time is measured in a couple of seconds, ventilation is not terribly important. If you're cooped up in a room together for an hour with 30 or 40 people, that's a different ballgame entirely. I am unable to make any changes to the ventilation in my office. It is what it is. We have standard HVAC, and you know, we have examination rooms that are large enough that, you know, I can sit across the room from people from part of the visit, but I'm face to face when I'm doing examinations and things like that. And we're relying on our regular HVAC to do the job. It is important to say that the virus is not generally transmitted through HVAC. It's not going through ventilation systems from room to room or things like that. So the value of ventilation is in getting air changes. It's one of the reasons why being outdoors is less risky than being indoors if you're around significant numbers of other people, because you have more air exchanges, and you also have you know, sunlight and wind and things like that that are playing into it.
Adam, I do have a question.
Okay, do we want to, Lily and Carrie, can you summarize really quick? I know there's a lot of buildings. If you could just summarize those three stages, that'd be great. And then we can get to Karen's question.
Great. So the full review was completed by Trane, and the mitigation strategy started several weeks ago. So they were really looking at both ventilation and filtration. There were, of course, a number of strategies that they needed, a number of things that they needed to fix, right? Everything from belts to transducers, and of course, those MERV 13 filters that did arrive. So they are in the process of currently being installed. In addition to, as I said, things like the belts, transducers, et cetera, as well. So they're getting close, and then we should be ready by October 5th. They're confident. Trane is confident, and the companies that we're working with are. We had a lengthy meeting today. And the timeline looks good for October 5th. And the report also too, Adam, I think you were talking about when that report will be up. That'll certainly have to be out before October 5th. So, both what was wrong, what was fixed, and when.
There was a question in the chat about oscillating fans, and do they help disperse the virus or spread it? I would say the answer to that is yes. Depends a little bit on where you are. If you're in a small room, the oscillating fan is not really doing terribly much. But if you're in a large room and the oscillating fan is increasing turnover of air with dead air spaces above you, then it's going to be very helpful. It also may depend if you are sitting in front of the fan or behind it, depending on the space that you're in. But in general, air movement is good.
You're muted.
Jeff, can you also speak to can you talk about aerosolization with COVID? Because we've been getting a lot of questions about that.
Yeah, it's a really complicated issue, and you know, people have tried to dumb it down to, oh, it's big droplets, or oh, it's little droplets, and I think that obscures the fact simply that it's complicated. It is certainly true that you will disperse far more virus into the environment if you are coughing and sneezing, or if you are vocalizing loudly, you know, if you're spitting consonants into the air, if you're singing, if you're panting, such as with athletic activities. All of those things probably increase the dispersion of virus. We really don't know if people who are asymptomatic are very efficient at transmitting virus to their colleagues or not. They may be. There's very little hard data about that, actually. But I think in general, there isn't any epidemiologic reason, for the most part, to think that the virus hangs around in the air for hours and hours and hours after you've left the room. If that were occurring, we would be seeing much more instances of people who are getting COVID when somebody was in the room next to them, or people who were at distance, who were not in proximity to one another getting COVID. And that really has not been observed to any significant degree. So by and large, proximity is really the key thing when it comes to droplets. If you are, the further you can get away from somebody, the lower the risk is. And it's really the people that you are with in the moment. It's not the people who were in the room 2 hours before you were there, for the most part.
This is Carrie. I would just add that I think this conversation around whether you refer to them as droplets or aerosols become more important if other things aren't occurring. So if there's not mask wearing, and if you don't have decent ventilation, and if you're putting people in like windowless, crowded spaces, then it may become more consequential. But when those other things are occurring, I don't know that, you know, the concern around droplets is quite so prominent, particularly if people are wearing masks and you have fewer people in a room and there's adequate ventilation. So to Dr. Snedeker's point and others' point, there are a lot of dependencies with any of these questions, which makes them very difficult to sort of answer in a very sort of black and white binary fashion.
Okay, we have a hand up, Karen.
So my question is, if it's safe for us to come back, why do the students and parents still get choice? Why don't we all just come back? And I don't mean like come back and do like we were, but do like an alternate day thing, half the kids there on one day and the other half on the next day.
Hi. So I have 3 kids that I'm sending back because I feel safe with what we're doing at the rates that we have in our school district. But I think, you know, everyone is coming from a different situation. And so I think that's why the district offered the choice, because they realize that some people live with people who are high risk, some people are high risk, some kids are immunocompromised and are at higher risk of if they go to school. But I'm not sure why we actually gave the choice. Carrie.
Karen, I think it's a really fair question, right? So if we're saying it's safe to open up schools, I think ultimately we do want to get to a place where kids are coming back, right? Physical distancing requirements as they stand now, and our current individual classroom capacities right now are dictating a lot of that, a lot of those our ability to welcome everyone back, right? But I think it's well said. Ultimately, when the data supports it, we may be in a place where it's come on back, right? Appreciate the question.
I guess I thought the data already supported it. That's what I'm hearing. I'm hearing the data does support that. And the answer that
Right.
you know, kids and parents might have things going on, that's true for us too. So it really is kind of just a slap in the face to say, you know, it's choice for students and parents, but not for staff. Because if it's safe, and we should all just come back.
And Karen, I think, you know, there are, of course, thank you for that. Yes, there are, of course, staff who live with vulnerable household members and themselves have medical conditions, of course, right? And of course, through labor law, that is clear, and we're continuing to work with those. Thank you.
So
There's a question about, oh, I'm sorry.
No, Carrie, go ahead.
Okay.
If you have something in front of you that hasn't been answered yet, go for it.
Yeah, no, and I appreciate, so the logical question that's come up out of our conversations about spaces and aerosols and ventilation is whether or not students or staff should be removing their masks at all at in the classroom, particularly like if they're eating lunch there, because that's the plan, not to have them congregate in large group spaces, but rather to sort of eat in their classrooms among their peers, their little cohort of peers. I'm going to share with you what the state guidance requires and what we're doing with respect to that. So the state guidance requires that masks are worn when you cannot physically distance. So anytime you cannot physically distance, masks must be worn. There are some districts, I think in maybe in our region, in the Central New York region, who once a student arrives to their desk, presuming that they are physically distanced in a classroom, they're allowed to remove their mask. The guidance goes on to say that it strongly recommends that students wear masks more continuously, with the exceptions of mask breaks and eating lunch. And so that's where we have landed as a district, that students would be wearing masks with the exception of eating lunch and taking scheduled mask breaks. I would add to that this decision, this approach is certainly subject to change if we find ourselves in a place where rates are increasing. And that is articulated as well in the guidance, that they would recommend effectively what our current approach is if we were concerned about increasing rates. So it's a fairly conservative approach at this time, one that probably exceeds where we are from a test positivity and case rate perspective. But again, if the providers want to say something about this, I welcome them to do so.
Why isn't lunch being offered outdoors?
I don't think there's anything prohibiting a teacher from taking their classroom to eat outdoors if weather permitting. The idea is that we just don't want multiple classes congregating in a lunchroom or a gymnasium or things to that effect. I don't think there's anywhere that we said that teachers couldn't take their respective class outside for lunch. And similarly, at the secondary level, we would be encouraging students to use outdoor spaces like at the high school, the courtyard, thank you, and similarly.
I'd like to echo, this is Dr. LaFace, I'd like to echo what Carrie said and what others have said, is that certainly eating outside is preferable. People are more at risk of contracting coronavirus from a positive person based on, you can think about it simply as three main things: distance, duration, and dose. So if students are in a classroom able to sit several feet away from each other and they're taking their masks off for a short period of time to eat or have a drink, then that's really causes a very, very low risk of infection if someone happens to be an asymptomatic positive. And just along those lines, sometimes people think, well, if their coronavirus test is positive, it's positive. Dr. Snedeker was talking earlier about how there might be evidence, RNA evidence of coronavirus in someone's nasopharynx, but that does not mean they're infective, especially if they are not symptomatic. So if we happen to have someone in the classroom who's carrying coronavirus, but they're not symptomatic, they're staying 6 feet away from somebody most of the time, not all of the time, wearing a mask, then that really is very, very low risk for the people around them. There was one study that I read a couple of months ago from France that looked at someone working in a grocery store who was positive, and they figured out what the risk was of someone in that person's household, someone who worked with them, and a customer coming into the store, and it was I can't remember the exact number, but it was really remarkable. It was like 1 in 5,000 chance of someone in the store getting it. Someone at home was more like 30%, and someone they worked with on a regular basis, it was well less than 10%. And this was back when all the public health guidelines weren't in effect.
Is it possible that I can jump in? Or I already am. Okay, so this might be a ridiculous question, but I'm curious on the doctor's take also on bathrooms, because we clearly have lots of communal bathrooms. People don't have very specific timed bathroom breaks. Like, what is the health and safety protocol in community bathrooms and how to deal with those spaces in the safest manner?
So with respect to bathrooms, and Lily, correct me if I'm getting this wrong, but the guidance is that we if, say, for example, there's 4 stalls, that we limit use to 2 persons, that we cut it in half. For the younger grades, the guidance articulates that they effectively should be monitored. So an adult would accompany a child or children who need to use the bathroom to ensure that not only are a limited number of persons using it at a given time, but they're engaging in hand hygiene. So for classrooms without bathrooms, like the ones that you're referring to, I think the ones that are more, located in hallways or communal settings, that we would need to employ those strategies. I've even talked with the nurses, during peak periods when a group, like a class, may be moving to lunch or moving outdoors for recess, that if there's like 5 or 6 kids who sort of immediately need to use the bathroom, that they should avail themselves of the nurse's office so they can kind of spread out the number of kids using a given bathroom at any time, particularly for our very young friends who maybe can't hold it long enough to wait. I hope that, is there anything you want to add about that? No. Okay. So again, in confined spaces, and this is true, I want to emphasize a lot of the conversation I know has been around students, but break rooms for staff, copy rooms, small conference rooms, we want to really limit the number of persons in there at any given time, and be very thoughtful about our distancing, our hygiene activities, and mask wearing in those settings. We will not be doing, potluck. We will not be blowing out a birthday cake in the break room for someone. We will not be serving things that are not individually wrapped. So in addition to thinking about your classrooms and spaces, I would encourage you to think about the spaces you occupy as a staff member, as an adult, that you are looking at, again, 50% occupancy at best, and maybe, walking to the copy room and seeing there's 2 people in there already, I'll come back later. It really is, in some respects, the fewer contacts you can have in a day, the better. So although our schools are very social environments and we enjoy the company of colleagues, the degree to which you can actually limit your contact with other persons in the building, maybe to just your students, yourself, and your co-teacher or something, or your aide to that effect, the better, really.
I'm afraid I'm going to have to leave the call now, but I did want to make an offer that if anybody has any questions that didn't get answered that have to do with virus biology or epidemiology or things like that, Adam, if you can collect such questions, I'm happy to respond to them directly. Again, in my capacity as a physician and pediatrician, not necessarily representing the district or the board, but I'm happy to do that if that would be useful for people, since we can't go until 10 o'clock tonight. And I apologize that I have to leave now.
And Dr. McQueen, who is the adult infectious disease doctor, also, Adam said you can do the same with him too, if there was an adult specific question.
Okay, yeah, I think we've got a good connection now. We'll figure out how to make sure that questions are being answered, and then I can work on figuring out how to filter them back to the people that aren't on the call too, because there's many people who couldn't make it but have questions. So thank you, Dr. Snedeker, for attending, and I think there's enough people on the call where we can keep going, but thank you for your responses before you sign off.
Thank you for the terrific questions.
So I know the other kind of big questions out there are related to just being in a school environment, not even a small restaurant, actual school environments, when you have underlying conditions, maybe not even anything that's bad, maybe just, going through fertility or actually being pregnant, for example. Like what are the medical research right now, and what are the comments back around people who are pregnant or those who are have a 6 or 7 week old at home who are technically done with maternity leave, but don't necessarily want to be exposing their newborn. So if you could touch on that a little bit, I think that would help. I know there's a big question around that I'm hearing.
Karen, I'm going to let you answer that one since you deal with grown-ups.
Okay, I'm unmuted now, sorry. There's not a lot of research on pregnant women. There was something that came out that I saw last week in the Journal of the American Medical Association. And it might have been the American College of Obstetrics and Gynecology that has some information on their website. I do not take care of pregnant women, so I will tell you that I'm not an expert in this. But for those of you who are pregnant or considering pregnancy, I think a really good resource is the American College of Obstetrics and Gynecology, and I would urge you to look there, and they have information there for the public. There is a slightly increased risk of not contracting coronavirus, but of becoming somewhat more ill if you do get coronavirus if you are pregnant. As I said, the numbers for research are not really high, and I don't think it's a significantly high risk compared to a healthy person. Non-pregnant person, but there is a slightly increased risk. And a good resource for everybody, whether you're considering pregnant or you have high blood pressure or diabetes, is I would urge you to speak to your primary care doctor. And if you need a letter, if you need some guidance, talk to them. I've done that for some of my patients who are teachers in the district, and either told them that, I do think you're higher risk. This is what I recommend for you. And others who had high anxiety about going back to work, who are very healthy, who I feel like are at very low risk. And so giving them assurance that I think it's a reasonable thing for them to go to work can be helpful too. So to use your primary care doctor or provider as a good resource.
Dr. Dendali, maybe you can speak on the very young children, newborns through more younger age.
Yeah, again, there's not that much data on it. I do know some of the children under 1, it seems, may get sicker, but again, there's not that much data. And I think what Dr. Lefebvre says is to talk to your primary care doctors, the pediatricians too, because they'll know the family and they'll know the risk of both the parents and the kid. I will say that, like Karen said, we have been working with patients since this all started. And I think the thing that, when we first started doing this and started seeing patients that could potentially have COVID, I was terrified. I remember the first patient I saw, I could barely breathe under my mask because I wasn't sure, how it spread, what my risks were. But now that we know that some of the things that keep us safer, like the PPE and the distancing and the hand washing, and we see how the risk of the transmission goes when we have all those things together, I don't feel nervous at all anymore.
Yeah,
so I think.
Sorry,
Go ahead, Karen.
Yeah,
go ahead.
I'm very comfortable in the office seeing patients, even when I know they have upper respiratory symptoms, because the masks, et cetera, as I've stated multiple times, works. I did want to also point out that I just looked today at the CDC for updates on people with certain medical conditions and risks. And there is a list there. It's called People with Certain Medical Conditions for the CDC. And people at increased risk, there are about 7 or 8 conditions listed, including diabetes, sickle cell disease, cancer. And there's another corollary here that people who might be at increased risk, but it's not really clear, are asthma, cystic fibrosis, hypertension. I won't read through all of them because you can see, and pregnancy is listed as one of the ones that might be at increased risk, but it's not really clear.
And I think age is a big one too.
If you're over 85, it's really not good to get coronavirus. If you're less than 50 and you're healthy, then it's super low risk. And then with each decade, you're at higher risk of having a severe illness.
Okay, so I know Lily has to get going as well. So
I'm so sorry, Adam. My sincerest apologies. I thought it went until 6. I'm so sorry.
Unfortunately, there really, like I said, there was no end time. It was more of a kind of like, oh wow, this could go till 10:30. It could go 2 minutes.
I know, and I'd love to hang out with y'all until 10, but unfortunately, I've gotta run. But I have those questions, and I had just texted Adam that I'll work on them on the weekends with other folks.
Yeah.
And the other thing, Adam, now that we know each other, we can potentially set up another call.
Sure.
The doctors in the community really want to help and answer questions because they know there's so many questions about COVID. So we can do that.
Right. So Lily, you don't have to answer this now, but just know that I am watching the chat, and there's a lot of question around how schedules are going to be around like lunches. So we obviously have very different levels: pre-K, elementary, middle school, and then high school, adolescent. So I'm sure there's going to be different models and thoughts and plans, but it does seem like that if that's not already in the list of questions, I think people are wanting how is that going to work, because you can't have large gatherings. I think some people think that there's going to be still cafeteria kind of mode. And if it's not, and if it's in classrooms, how is that actually going to work? Do we have enough ESPs to cover so that teachers are not in there? So there's a lot of questioning around that. So I think it's a mix between the medical question of how you do mask breaks in eating and drinking, and then how that mixes with a schedule. So they have to come together. So I'll let you go, but know that that's the schedule piece that we need you to answer. And then maybe we can turn to the doctors about what is the medical side of that. Like if you are 20 minutes or longer without a mask on while you're dining, what is that supposed to look like?
Thanks, Adam. Appreciate it. And thank you all. It was great to see you. Appreciate the questions. Talk soon. Thanks.
Unfortunately, I need to go too, but I really appreciate the opportunity to speak to you. And I'm not an infectious disease specialist, but if I can be of service or help to anyone, please reach out.
Okay, thank you for joining us and answering our questions. Carrie and Dr. Dendali, do you have any, maybe you could answer that one last question and then we can figure out how to wrap it up since people are having to exit.
I can, again, it's dining in close proximity versus dining outside versus dining 6 feet apart or 12 feet apart. I mean, I don't think I have I guess as you get farther, your risk gets lower. And I don't know, and I can ask Dr. Snedeker if he knows, but I'm not sure if there's a time frame. So if you're in a place that's well ventilated and you're 6 feet apart and you're eating without a mask on, what are your risks versus dining outside? What are your risks versus, not dining at all? I'm not sure. But I haven't seen outbreaks in restaurants, and people are inside eating in Tompkins County. And so far in all the restaurants that have had outbreaks, I don't think there's been transmission within the restaurant, right? So that might go to.
Yeah, there's one, I think, in China that gets cited quite a bit. And one of the things that arose out of that was the fact that the restaurant was using an air conditioner that recycled air. and that I don't know that diners were necessarily sitting distance. This could have been very early on in the pandemic, so it may not have been that all the measures in place. But I do know one of the variables there that complicated, and effectively led to transmission was the fact that the air in the air conditioning unit was being recycled and sort of put back out, and so that may have actually facilitated the spread. But what we've confirmed with our HVAC assessments is that our systems are drawing in outside air, and we're also adding a higher level of filtration with the use of MERV 13 filters. Teachers are also being advised to keep their doors and windows open to promote, again, the exchange of air in addition to whatever the HVAC system is conducting.
And I do know also, for example, with the boathouse, where they had a positive case, the contact, as far as contact tracing, the people that the Department of Health were worried about and quarantined were close contacts. They weren't the diners. The diners, they just said you can get tested, but they weren't asking them to quarantine, and they thought their risk was very, very low.
Yeah, this goes back to that constellation, right? Proximity, how close you are, duration, how long you're in that close proximity, and then exposure. So someone who, for example, a school nurse that is looking in a kid's eyeball, right, has a potentially very high exposure, even if the time that they're seeing the child in that proximity is short, right? Because the kid could sneeze or cough on them. So that's why they're going to wear a face shield when they're doing any kind of really close assessment. So again, this is why some of these questions are difficult to answer, because there are a lot of factors that play in. But that's why, again, we're looking to use a layered approach, because any one strategy, even testing or mask wearing or hand washing, is not 100% perfect. And I think we said it before, and we should say it again, there is no zero risk. Zero risk is March 14th. Everyone's sitting in their homes, not going anywhere, not touching anything, not doing anything. And so with the reality that we may be living with this, not just for months, but years, we're trying to figure out how to live with it. And so that's why, again, the layered approach.
The other thing, this is just personal. I have 2 kids with asthma, and I feel I feel safe. Of course, I'm anxious. I get anxious every time they go to school during flu season too. But I feel like the school is doing everything they can to protect my kids. If they weren't asking kids to wear masks, I would have not sent them to school. But I think that the layers of protection they have make me feel like the risk is low and the rate in the community. And just like Dr. Snedeker said, Cuomo said that the rate of 9%, I would not feel safe waiting till then. And I would make a recommendation to the school district and ask the Department of Health to probably close if it was getting that high too.
So Nancy,
and you can I freak out about stuff and I call her and send emails and before changes are made.
So Nancy has one more follow-up, probably about young kids being outside. So we'll let her go really quick.
Yeah, it's just a request, and of course it's a little premature because it has to do with cold weather, but I fully intend to try to get kids outside as much as possible. But every year before the pandemic, I would get requests from families to keep their kids in from recess at certain times because of the belief that you would get sick by being outdoors, that being in the cold actually makes you sick. And I was an awkward position to be in because I'm not a medical professional, but as far as I understand, the science is the opposite, that in the wintertime, you actually should go outside and get fresh air. And so I just want to ask that you try to do that messaging and, think of it within the, culturally responsive piece too, because I think that sometimes it's like a widely held belief among families.
Yeah, we can do that. And the other thing is we realized last winter that each school had a different threshold for when they kept their kids inside. And so we will make that consistent throughout the school district. So, if it's 20 at Cuyahoga Heights, it shouldn't be 10 at Fall Creek, right? And so we started to do research on that. I would say the kids in Toronto go out if it's like negative, but I don't think we'll make it that low. But we will have a consistent temperature throughout the schools. if that helps.
And families may feel very differently this year based on, you know, the very little lack of evidence for transmission in outdoor settings. They may feel very differently about when and how we use our outdoor spaces. So we can certainly work to message that and work with the pediatric offices to do the same.
And the Department of Health.
Thank you.
So how about one last question or a hand raise that somebody wants verbally answered, even though I'll do what I can with everyone to try and get the answers that were in the chat that weren't answered. But if there's a verbal one that people want an answer before they log off, let's do that one right now. So here's your last chance. Go ahead, anyone? Okay, so it's almost 6:45, and most of the people of the panel have logged off. So there's still a lot of people listening, but I think what we need to do is kind of bring this to a close. So let's thank the last two people who were in on the call as our guests. So thank you, Carrie and Dr. Dendali, for answering these questions and continuing to say that you'll do all you can to answer our questions, because our questions today are going to still be our questions tomorrow, and there's going to be new ones. So it is going to be a constant kind of churn around of new questions that always have to happen, and I'll connect with you tomorrow to figure out what the best system will be to feed you the questions, and then you feed me back answers so I can help communicate that out.
And I realize that sometimes our answers are super vague and we don't necessarily know the answers, and it's super frustrating. It's frustrating to me too. But what's happened since March is that every time we make a plan, it changes and there's more questions, like you say, Adam. So we'll constantly be reevaluating, but we also need you to give us your input, and because you see things from a different way also. So thank you for talking to us. And Adam has my email and my cell phone, and he can give it to you. And if you text me, I will text you back or call you. Again, I have 3 kids at home, and so it might not be right away.
So whoever else on the call, there's a Google form that was in the email where you got this link from. The form itself is not shared with the panelists, but there's a way that you can share the response page, and that's why it's just that one question. You're just submitting a question that you have, so they should be seeing that grow. You can always be putting a question in there over time as well. You don't have to now go, oh shoot, the Zoom is over, now I need to figure out another way. Like that, I'll leave that form available and open for you. So thank you everyone who was able to attend the call, and I'm hoping that this helped. And you're right, we might need to do another one here as we get closer to October 5th.
Great, thank you.